Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. All right. So...
Here we are.
Here we are. We are going to do some more video stuff today for you. So we are going to talk about ethical dilemmas or somewhat ethical dilemmas. I don't know. I feel fortunate. We don't have to encounter this as dramatically as some do.
I feel like in true fashion, ethical things, I feel like we don't talk about because they're kind of icky to talk about.
Yeah.
So we're going to talk all about it.
Yeah.
We're going to go into all the things.
It is important.
Yeah. So working in medicine, I think it's really important to understand that we try our best every single time, or close to our best, right?
Yeah.
I mean, we try our best every single time. And doing what's right for the patient does not necessarily mean doing what the plan is.
Yeah.
You know?
Yeah.
And I think allowing us to call ourselves PAs, we have a certain moral and ethical compass that we have to navigate all the time.
Yeah.
And certain stressors or certain variables will make us shift that ethical rightness.
Yes.
But not to the point where we become bad people or providers.
No.
But there's gray.
Yes.
It's very gray.
We are existing in that gray area.
It's murky.
It is a murky water. It's much like the pond I'm looking at right now.
After a rain.
Yes.
Yeah.
The pond after a rain is how I feel.
Yeah, but there's no unless you look at scenario, there's no real way to walk through ethical situations until you're in them.
Yeah.
And sometimes life medicine does not allow for the time to do that as extensively as you do. We don't have board meetings where we're hey, let's talk about our ethical stuff this month. Yeah. I feel like it happens and your brain just has to click and do the right thing and question it afterwards. So we're going to unpack.
Yeah. Let's unpack ethical dilemmas. So ethical dilemmas for PAs, and we'll specifically touch on our experiences with it more in the ortho world. We're not in a hospital setting where we're dealing with the ethical dilemmas of life and death scenarios and end of life decision making and difficult things like that. So, I'm
not finding Hannah sitting on a bench looking out the window being
I mean,
show me a sign.
Sometimes you might. maybe never say never.
Right. But no, these are more subtle. They're not necessarily emotionally heavy, but there's something I think it's worth talking about because we deal with it literally every day.
Yeah. So, okay. One thing to touch on, working under a supervising physician in that role. And I'm just going to briefly touch on this because I feel and I'm sure you agree, hopefully we're both fortunate that doesn't really contribute to a lot of ethical dilemmas, but it can from a PA relationship.
I think worth mentioning that both of us, and again, I'm talking for you, are aligned with our physicians as far as our ethics are concerned. Yeah. So I think we are lucky enough that we work with surgeons that we agree with their decision making.
Right. Yeah. And I honestly I would argue if you work with somebody that you don't agree with their decision making, find another job.
Yeah, 100%.
Yeah, you don't want to be in that situation. No. So things that can go awry with that. I mean, disagreeing on when surgery is appropriate versus inappropriate, someone that doesn't want to exhaust any conservative treatment options or, very quick to recommend surgery, things like that. Or, brushing off certain complications and things like that. We don't have to deal with that. So,
yeah. And it's very easy not to have those conversations. Let's say you see a train wreck patient that has, let's say, for you, right? It's elbow pain. You're going to do a lateral epicondylar debridement and repair. And then you meet them for pre-op and they start going off about the neurological symptoms they're having and also the pain on the medial side of the elbow. And you're I'm not sure the surgery that we are talking about today is going to wholly get you better.
Yes.
So do we say that because then now it's a 20-minute conversation about that?
Yeah,
and
because
then you're delayed for the rest of the day, or do we leave a nugget?
Yeah,
saying "Ooh, well, just so you know, these neurological symptoms, that's something we can talk about afterwards." You package it up
Yeah.
And save it for later? Do you dive into it there because you want the patient?
I dive into it there. I mean, I get behind because I'm in my mind, I'm like, I'm preventing my future self from getting behind. Does it work out that way? No, I'm still getting behind in the post-op visit because something doesn't translate. And this is, I was talking to my staff about this week. This was a frustration actually this past week for me. Like I wish I could like record myself some days. I'm like, I know I cannot be that poorly at like explaining things.
Yes.
But they're forgotten or
I know.
Something like that.
Well, there's also the thing, patients hear what they want to hear. Like if I go into a visit and I'm going to go see my doc for whatever lab discussion, I'm already aligned with the fact that my labs are amazing. So when they tell me they're not, I'm kind of like, okay. I already decided they were, you know, and I think patients are the same way. Like they'll come in, like if you see a patient who needs to only be in a sling for 4 weeks, that's all they're going to hear. Mm-hmm. You say 6, like, well, it's like 4, right?
Yeah.
You know,
close to 4. She told me 4.
Yeah, she told me 4. 6 is close to 5 and 5 is basically 4. So.
Yeah. So what are we doing here?
Yeah.
But back to that. Yeah. Like I will definitely address it at the time of, okay, so this is what we're planning to do. But based on what I'm seeing here, I don't necessarily want to guarantee you that like everything you're describing to me is going to get better from this procedure. And at least, you know, have that honest discussion so that people are not going into it with the mindset that you promised me you were going to fix everything. Yeah. You were going to fix me.
But isn't that funny? Because you are the PA, you're not the surgeon. Yeah. Like the anger, let's say, at an incomplete result is not necessarily at the PA. Well, again, we'll pause on that.
Sometimes.
You're kind of protecting the surgeon, right? Yeah. So I think the right thing to do in that case, is to outline all of the, you know, the risks, the complications, and then proceed with knowledge. Yeah. Do you ever get but the surgeon didn't say that?
No. Or because I think they forgot. Yeah, like
that's not what we talked about.
They forgot that conversation too between theirs and mine. Yeah. So yeah, I it's crazy how like that. It's like the game of not phone tag. Is that what it is? Telephone. Yeah. Right. Like
yes. They said yes. At the end of it. Yeah.
At the end of it, it's just like a totally misconstrued.
Yes.
Nobody knows what was said at the beginning anymore. Yeah. But yeah, I think that is a big thing. Just like protecting yourself. Protecting the team from those instances.
And the other things that weigh on that, like let's say you have the discussion with the train wreck patient and maybe you decide like they say things, right? Like, well, I have an example. I have a patient that is a prominent political person in the area and we're going to operate on the shoulder. And the patient had an A1C that was 9.6. That's like really high. Mm-hmm. And called the patient and told the patient like, hey, your A1C is really high. And they're like, and? Mm-hmm. Like, well, we're not going to operate on that if it's that high. He's like, what's your number? Well, if this were a total joint, less than 7. He's like, mine's never been less than 7. Mind you, the surgery is 2 weeks away. Yeah. So I was like, all right, well, let's see how low we can get it. He's like, whatever, I'll go through the holiday. Let me test right after the holiday. I was like, it's a terrible idea, but okay. So I'm like, let's see if we can get in the 8s. Yeah. And I didn't hold it true and fast but like it just needs to be better than 9.6. So he gets it and it's 8.9. And he was like,
it's not 9.
He goes, it's not 9. It's in the 8s. And we ended up canceling him. And, you know, the whole question was like, he's a VIP. We try to treat this patient well. Yeah. But at the same time, the right thing to do was cancel him because let's say statistically he goes through the surgery and he's just fine. Which he might, but being a diabetic with an uncontrolled A1C, the chance of infection and rotator cuff failure is pretty high. So like, you're going to be mad at me afterwards if that's the case. And let's say we proceeded. Let's say he did great. I'm the asshole. Yeah. I'm the asshole that had like stickler rules.
Either way, you're the asshole. Yes, because as the VIP person, right? Like not that, again, like you don't want to treat anybody differently, but like, aren't you actually doing that person a greater favor by like paying more attention to those things and stopping them and being like, hey, you know, you're doing something not great for yourself. Yeah.
I mean, it's like punishing my kids. Like I'm like, they'll thank me one day.
Yeah.
They don't.
They
don't ever thank you.
Maybe one day. Yeah.
Yeah.
But it's told my parents last week. I was like, yeah, remember all those times that like you told me you wished that they wanted to sign me for piano or music lessons or something. I'm like, I wish you had, like, I wish you had forced me.
Yeah. I wish I was more well-rounded, Mom. Thanks.
Yeah.
No, but they never say thank you. But anyway, I think if you feel like something's off and you know the right thing to do, even if it in the moment unearths like an emotional tension, you just have to.
Yeah. And I don't know that this part, I made myself a note, is like an ethical dilemma, but I also feel like as the PA, you have to be the person who's like on 100 all.
You have to be, you're the gatekeeper. You're
the gatekeeper, but also like you don't as much get, and I tell students this a lot too, like you don't get the luxury as much of being wrong or saying the wrong thing. Yeah. And I'm not saying that like physicians want to be wrong or are okay being wrong. Yeah. But I mean, you hear all the patients all the time, like maybe you see for a second opinion, they're like, oh, like the first doc that saw me, it was a complicated thing. They couldn't figure it out. But if as the PA, you make the wrong call or can't figure it out, like it's because you're a PA and you're stupid.
You don't have the capability of getting it right.
Yeah. So you just have to like, be at that level. Yeah. All the time.
Have you ever gotten to the point, let's say it's a surgical thing or you're in the midst of post-operative care and the surgeon looks at you and he's like, why did you ever let me operate on that person? Have you ever had that being said to you?
Yes. We've all, I know you have. Yeah. Yes, those experiences do happen.
Because you have that little like thing in your brain when let's say you're going through pre-op discussion, you're like, red flag. Orange flag. Mm-hmm. It's another red flag. Yeah. And like how many red flags are too many red flags?
Yeah. You know? I mean,
I'll call them orange, yellow and orange, like a couple yellow and orange. I'll be okay with.
Totally okay with. I'm going to be honest. 90% of the population is yellow and orange flags. Yeah. I have several myself.
You got a couple yellow flags.
So, I mean, I've got to have some grace with that. But the red ones, yes. Yeah. Typically for those people, I will like try to make sure that I don't want to be the decision maker for that patient. So if I see somebody with red flags, but I'm like, there's a surgical indication, like they are going to also meet my surgeon before, because I want him to be the one to have to make the final call.
You'll look at the red flags, but you won't look at them. If the surgical indication outweighs the red flags, we still proceed.
Yeah.
Okay. Question. When you don't address the red flags, or if you like sweep them aside, like what are you concerned about is it like disrupting the waters? Like what makes you not say that? Because you know where it's going to go?
Like, do I ever not bring up the red flags?
Yeah. Or like the orange or the yellows.
I bring them up.
You bring them up?
Yeah.
All of them?
Yeah.
Okay. Even if someone's a redhead?
No, I think you talked to admissible thing?
Okay. I have talked to someone. Yeah. I literally said to someone, we operated on their knee recently, and I was like, there's certain things, immeasurable, that make me feel like you're not going to have the best surgical outcome.
Oh, to the patient, not necessarily to the team.
Yes, sorry, to the patient. Yeah,
yes. Yeah. Oh, yeah. I will totally, to the patient, bring up their orange and red flags to them.
Okay. Yeah.
Yeah, because I want them to have, the expectation that, hey, like, you're going to do everything you can on y'all's end, but like there's something that I'm contributing to this too.
Or I'll say to the patient, like you have certain things stacked against you, aka your fair skin, your redheadedness, your inability to tolerate pain. Like those are things I can't change. Yeah. And here we are talking about a surgery where we're then going to inflict some difficulties on you. Yeah. And I just want to let you know, like there's a possibility that your success is going to take a while to see.
Yeah.
Something like that. And I will have those conversations.
You're going to have a prolonged recovery.
And I'll tell you, like, I'm sweating because I don't know how it's going to be perceived. Yeah. I'm 100% certain that discussion has not happened previously.
Yeah.
Especially if this is like a 40-year-old, that there's always the risk that they've never heard that before.
Yeah.
Should have. Yeah. But no one's told them that before.
Yeah. I mean, in my mind, worst case scenario, I get a 1-star review, right? Yeah. Best case scenario, they have a new understanding of themselves and we're in the clear.
And I get a thank you letter.
Speak. Yeah. And like they actually, like we go through the post-op course with them understanding like, oh, okay, like this is what we kind of expected. Yeah. But I want to prevent on the front end, that from being like a dumpster fire of like, oh my God, nobody said this was going to be painful. This is the worst thing ever. Why did you tell me this was going to be so easy? You promised you were going to fix me.
That still happens though, because like whether or not again, with my redhead patient, I'm kind of plowing through that, and post-op, she said to me, she goes, I'm 8 weeks out. Shouldn't I be further along? And I was like, shouldn't you be further along?
Like,
or shouldn't others be further along?
Yeah.
Without saying it like that, you know? And now that we're in it, we're in it together.
Yeah.
And that's always going to be my patient.
Yeah. Yes.
Yeah.
Yeah. Those are your patients.
Do you have any specific scenarios that you can talk about where you've had kind of that ethical, like, should I, shouldn't I, or like icky feelings about stuff?
About patients, like
Mm-hmm.
specifically related to that. I mean, I've had several patients that, I see them for pre-op visits, and I'm very much questioning, like, are we going to get better after this?
Yeah.
Is this?
Do you think that's the most common thing that you see where you feel like you're like, all right, we're going to have this conversation?
Yeah. That's probably like, and I don't know if that's necessarily like an ethical or a moral thing as much as just like an uncomfortable level of honesty thing.
Yeah, I think
like it's a difficult discussion to have with
those
people.
are all relatives of themselves.
But yeah, I mean, every single day
that
I have that, or like if it's somebody that we have not had that conversation with post-op and having to guide, or pre-op, having to guide them through it after the fact.
Yeah.
But yeah, that's more just like difficult conversations to have.
Yeah. What about patients that ask you to change their documentation? So we live in a world where it's EMR, paper chart, never a thing, because paper charts were stored in a beautiful like bookcase, right?
Yes.
Where patients never got to see it. Now EMR, like the second you close your note, there's a highlight of your note or your entire note that is posted for the patient. So the, areas of the note, the HPI is basically you dictating what the patient told you.
Mm-hmm.
God forbid you get something wrong.
Yeah.
Right. And then your assessment is what you guys talked about.
Yeah.
So will you have patients that will read through your note and then ask you to change or tell you it wasn't accurate?
Yes, 100%.
Yeah.
Yes.
Is it more so in the HPI or in the assessment?
It's a combination of both. I mean, sometimes it's, stuff as little as like, oh, the laterality is wrong, like whatever. Like, I'm not saying that's okay, but like that happens. Like these are buttons that get clicked and rapidly. And sometimes that happens. And obviously those are getting fixed. It happens a lot for like, obviously workers' comp cases and things like that. Yeah. And that, like, unless I can recall like, oh yeah, I am in the wrong here, I forgot to document that, in which case I will change it. Otherwise I'm not typically changing my note.
But how do you respond to the patient? Thank you for your feedback. I will look into it.
I delay the response
as
long as possible. Yeah. Because again, like on the list of uncomfortable conversations to have, like, if I'm going to be perfectly honest with them, I'm going to say like, hey, like I'm documenting what happened during the visit, and I cannot legally add anything else to it. Yeah. It's done.
So I run into that a ton. And I had a guy, I remember this, it was here. This was in the past 10 years. And the guy is a workers' comp injury. The guy tore his quad. He tore his quad getting out of the shower when he was on call. So he's on call, his pager, whatever it was, went off. So the pager went off first. Yeah. Then he tried to get out of the shower. Then he slipped and fell and tore his quad. So it was very important to the patient that it was documented in that order, as opposed to before the shower, or during the shower. He needed me
because the call incited him to like
now
rush
on the clock. Yeah. And in that case, I think like the way that I said his pager went off and he fell or something. Or he fell in response to a call. And he's like, I know it's nitpicky, but can you please go back in and state it as such? And I'm like, ooh, I don't need you to tell me how to write it. But I am respectful of the chronological events. And I have done stuff like that where I'm like, okay. I have this other guy who works for the Department of Labor, and he's a mail sorter, carrier, deliverer. I don't even know.
The mail stuff. Oh my God.
Like if I could never see a Department of Labor mail carrier ever again, that'd be amazing.
Yeah, same. Yeah.
So he had surgery on his left shoulder 20 years ago, and like a couple surgeries. Regardless, he's been a mail carrier for 20 years. Yes. His busted shoulder has been working for him. Yeah. So he fell at work, whatever the situation was. We see him get an x-ray, terribly arthritic shoulder, and get an MRI scan, and he's got rotator cuff compromise, not a full thickness tear, but enough where it's hurting him. Mm-hmm. Yeah. So the physician that I work with had seen him for a surgical consult. And like the physician I work with does rotator cuff repairs. He does not do reverse total shoulders. So seeing this patient for the injury, talking through the HPI he had no problem with, go to the assessment. The assessment was end stage glenohumeral osteoarthritis with rotator cuff compromise. Unfortunately, I do not think this patient is a surgical candidate for me for the rotator cuff. If he needs something, it's a reverse total shoulder. In the meantime, I recommend therapy. And comp denied everything. No treatment. So the guy came back in for his follow-up. He had done no therapy because they didn't approve it, to see me to just talk about the wording in his note. Has that happened to you often?
Yeah.
I've done it twice with this guy. So when I saw him, my brain goes to, I need to explain to this guy the correlation between a dysfunctional rotator cuff and the setting of osteoarthritis. So I took it clinical and he looked at me and he was like, so can you take arthritis out of my note? And I was like, no.
This is not about like them getting better at this point or understanding their problem. It's literally about, and I hate that stuff.
I hate that. So
I want to do the medicine things. I don't want to deal with the BS.
For the patient. Yeah. And again, does his arthritic shoulder that was existing perfectly fine for 20 years, does it now hurt more? Yes.
Yeah.
Did he maybe hurt his rotator cuff? Maybe. Yeah. Right. But I think now it was like a volcano that was dormant that now has erupted. Yeah. It's like the thing that put him over the edge. And I explained that to him and he was kind of like, oh my God, that makes so much sense. Can you put in my note? And I'm like, oh my God.
No, I can't change. But like the conversation you have with patients who fall and have arthritis and they're needing to come into urgent care and you're like, oh, you have arthritis. And they're like, but I never had knee pain before.
Yeah.
So did the arthritis come from my fall?
Yeah, but your BMI is 52. And they're like, it's always been 52.
Yeah.
Like, right.
Yeah. Listen, you have awoken the beast.
You have awoken the beast. But that is exactly it. Like something was sleeping and now it is awake. Yeah. But patients love to correct the documentation.
Yes. Yeah. I had a patient that I was seeing for several months, male person.
Department of Labor.
Department of Labor.
A postmaster, perhaps.
Someone who worked with mail. And in carpal tunnel.
Yes.
Right?
Yes. Yeah.
Biggest pet peeve in the world, workers' comp for carpal tunnel.
Yeah. Because they'll eventually tell you the other side too, right? What? They'll tell you the other side.
Oh, yes. Yeah.
It's my right one, but now it's my left one because I'm compensating and whatever.
Yeah. We all use our hands for our job.
Yeah.
It's not, your job didn't give you carpal tunnel.
Yeah.
So anyway, saw them for several months, offered them all of the typical things for carpal tunnel, start with injections, all the things. Declined everything. Didn't ever want to do steroid injections, bracing, therapy, whatever. And kind of just disappeared off the face of the earth for a long time. Forgot about them.
Which is weird because you have to see them back once a month.
Yeah. So no, but they weren't workers' comp yet.
Okay.
Yeah. So I was seeing them just for carpal tunnel and, they disappeared, whatever. And think twice about it. And then 6 or 9 months later, come back and brought all of this paperwork with them to excuse them from work for the past 6 months or whatever it was.
Yeah.
Because they haven't been working because of it.
Yeah.
And I'm like, no.
Yeah, I'm not doing
I didn't take you out of work for this. And also you didn't even try to do any of the things we recommended. And at some point, I think we even got a nerve test and we started recommending surgery and they just didn't move forward with anything, but just wanted the documentation for the time off. And I'm like, no, but then
I hate that.
I'm the asshole.
You're definitely the asshole. Yeah. Do you ever see a patient, and I'm thinking about one I have specifically, it's a workers' comp patient. She was walking, she was the security guard for a prep high school. So she's walking on the grounds, it's uneven, whatever. She's 24, she'd be able to do it. Twists her knee and falls. MRI is completely normal. Comes in, cannot move her leg. In that situation, do you call their bullshit or do you run through and work her up for all the things that it could be? Meaning, I did an injection in her knee. You fall, you go boom, right? You inject her knee. Oh no, made my pain 10 times worse. Okay, we'll try nerve blocks. Let's get the pain under control from a non-intra-articular source. I go to inject her knee with the cleanser, whenever she, and I'm like, okay, talk about yellow flags, orange flags, right? So physical therapy, can't progress in therapy, cannot do it. She's 24.
Yeah.
I go to examine her and she's like, so now my head is bullshit.
Yeah.
I mean, not now. I mean, it was the entire time. But
and
at
this
the
is
same
not
time,
us saying like, like rating things off, but there's expected things. Like if you know what you're doing in medicine, when you know what to expect with things. There's not a thing that will cause that.
Correct.
So
So then now, okay, and ethically, I don't want to waste either one of our times treating her orthopedically for a non-orthopedic issue that is located north of their neck, right? So now I'm thinking, I'm gonna have the conversation. So I have the conversation with her, and I was like, listen, sometimes our bodies work in funny ways.
Sometimes our brains and our nerves react.
When we have pain, our nervous system goes like crazy. Yeah. So now CRPS, right? So there's some type of CRPS, which again, if you've ever seen patients with CRPS, it's a thing. You can't really diagnosis of exclusion, right? You're not going there first. So we talk about, so now I've seen this girl for like, I can't even tell you how long. And workers' comp wants to know, can she work? Of course she can't work. She tells me, she goes, I can't even walk. I'm like, well, how'd you get here today?
Yeah. Like,
how did you? What? So I feel like I'm like, am I helping her?
Yeah.
Am I doing anything right for this girl? I don't want to write her off because I'm annoyed.
Yeah.
But I also want to treat her appropriately. So ethically, I'm kind of like, do I continue to order tests for you?
Yeah. Ethically though, who are you, who are you disservicing at this point? Because you also have to think
myself.
of
the answer is myself. Okay.
You have to think of like the ethical boundaries though for like the workers' comp system and like, and
the money and the time,
insurance
her,
and the government, all of that stuff, because I'm not going to bullshit that system either. And like, that is also medically wrong to continue to facilitate somebody, being off of work and ordering all these things that are unnecessary. So they can milk the system. Like that's wrong too. It's also wrong to like just immediately not believe somebody and not do anything for them.
Yeah.
But like, there's a line.
So the doc that I work with is so good at this because again, like he wears the hat, he has the hat, he is the surgeon, right? So he'll say to the patient, I have nothing to offer you.
Yeah.
Like I have nothing to offer you. And for him, that's so easy. It's so clean.
But Beth here
doesn't. But Beth here
has some stuff for you
for the next 16 years.
Yes.
So I feel like I get that part of it. And I've said recently, because I got a couple of them right now, that I've said I have nothing more to offer this patient. And then they come back.
Yeah, no, I know. And I'm like, what is the definition of insanity for you as the person? Like continuing to come back. In my mind, a normal sane person is going to be like, well, clearly this person's not helping me. Should I go somewhere else and get a second opinion? And I wish you would.
I wish you would.
But when I keep seeing them back and like I've explained to you, I don't have anything else for you. I don't know what's going on with you. The surgeon doesn't have anything to offer you, but you keep coming back. I'm like,
but there's this borderline personality thing that occurs with the patient where they're like, but I really want to see you. Yeah. And I'm like, why?
It's because I'm nice to people and I assume you are too. Like I'm not disvalidating them, but I'm also try to be honest at the same time. Whereas maybe should I be more of an asshole? Should I just be like, get out?
No, I know. I think the words I have nothing to offer you, it makes me feel like a failure. But if I were a surgeon, I mean, clean cut, move on. That makes sense to me. Like I am a surgeon and we're not operating on you because this girl will never have have a surgery. So
Yeah.
I don't like those ones.
I don't like that either. Yeah. I mean, yeah.
So,
but that is where we exist. That is our role in life.
That's the grayness of it all. All right. So let's say it's December. And again, December is my word for any time that you want it to be over. Okay. Let's say it's in December. No. I'm just saying, like, let's say it's December and let's say you have like 100 patients and you're behind. Like, what shortcuts do you make to get through your day?
Oh gosh. You mean like this morning when I got the email to close my
Yes.
I was like,
yes.
Well, we have a lot of like macros. We have a lot of like dot phrases and things to make our documentation easier. But getting into the documentation thing, huge pet peeve. Everybody in medicine deals with this. Like that is, again, I don't know that I want to call it like an ethical or moral thing, but I guess it is in a sense like you have to make things a certain way for billing and insurance purposes. And that's what you do.
So for instance, right, insurance companies, unfortunately in orthopedics, dictate, can we get an MRI and can we operate on these people? So there's certain insurance companies that have algorithms where, let's say I fell walking in today and I completely busted my shoulder and you examine me and you're like, you tore your rotator cuff. Yeah. You want to get an MRI. Insurance company says, nope, you need to try 6 weeks of conservative treatment.
And you're like,
Yeah.
What is that going to do?
What is that going to do? So your note has to be written in such a way that conveys the immediacy of needing the MRI scan and also why they're not doing therapy.
Yeah.
And let's say you do, and it's great, and it's artistic, it's amazing. And they're like, denied. Like, then we get on these peer-to-peer calls, and then that's your opportunity to speak with a physician reviewer who, by the way, every time you get on the call, they want to tell you all their credentials. I'm a board certified orthopedic surgeon that specializes in rotator cuff. And you're like, perfect. Amazing. What do you say? And again, we have to say things to get the MRI scan approved. So what is your go-to, like in that situation?
Chat GPT.
Patient comes, well, I know. Well, patient comes in and they clearly, at least you think, tore the rotator cuff and you think they're going to need surgery. So what do you say? Like
in the note or to the patient?
To the physician reviewer.
To the physician reviewer.
No, on the note you say.
In the note I say, we need
to get an MRI. Yeah. To the patient, you're like, you tore a rotator cuff, and I will see you back to discuss the surgery after the MRI.
To the physician reviewer, I begin to argue, well, what is therapy going to do for a massive rotator cuff tear like that? That isn't going to heal itself. And we start to have that discussion, and then they start tripping over their words, and they're like, well, blah, blah, and you're like, then, shut up. What you're saying doesn't make any sense.
I know. But then you get the ones that are like, I've been in practice for 30 years, and I know that if it's a full thickness tear, nothing's going to change with 3 weeks of therapy. And you're like, okay, thank you for your time. But like, if you're advocating for the patient, is the right thing to skew reality for the patient to get their result?
Yeah, I'll do that.
Okay. Yeah. What is your verbiage?
Like somebody comes in, and so I guess maybe I'm just fortunate. I haven't had this issue as much with like acute tears of things and not getting approved if I word it in a way in the note, like getting this for surgical planning. For surgical planning is key phrase. Yeah. Key phrase. So if I see somebody and they fell, I think they have a full rotator cuff tear, I don't word it like, oh, we discussed fit therapy versus injections versus, getting an MRI. I say discussion. Like, I want to get an MRI for surgical planning for their complete rotator cuff tear. That's key. Yeah. I will say, and again, I think Medicaid is the one that is like, no, must do 6 weeks. Like they just, and then they have a hard time improving the therapy too. So you're like, what? Yeah. No, I will say my go-to is patient tried therapy. It's too painful. Yeah. Sent back to me. Yeah. Could not tolerate it. Sent back to me because of whatever. Sometimes they just have to do the one session and the therapist say like, couldn't tolerate it. Yeah. Or you have the patient that we've been seeing for 3 years. Yeah. They did therapy 6 months. Then they took a break. Then they come back. You see them, you did an injection. They do therapy for like 3 months. Then it's another 3 months. Then they come back and then you get the MRI. Have they done 6 weeks of recent therapy? No. I had that one this year, collectively, they've done 162 visits of therapy for this issue. It was for one of our total shoulders, and they, oh my God, insane. So I still I'm angry about this still. Scheduled for a reverse, had them on the table, like they were asleep and started going into an abnormal rhythm. Oh. And no history of it or anything, no previous cardiac history. Yeah. So on the table, asleep, anesthesia, we cancel it. We're like, not safe to proceed. Yeah. This is what's best for the patient. Everything was already open. Like we were ready to start. So we cancel them. The patient, of course, understood, thank you for protecting me. Yeah. So send them to cardiology. They get the full workup. I can't remember off the top of my head what they ended up having done. But anyway, 9 months later, cardiologist clears them for surgery. I see them back around that time for another pre-op visit, get all the new stuff that we need together, labs and whatnot. Insurance comes back and denies the surgery. Oh, no recent treatment. Yeah. They're like, okay, but they haven't failed therapy within the past 6 weeks. And I'm like, but they did last year, and you approved the surgery and they were on the table, but they had a cardiac complication. Yeah. And so that's why we didn't proceed at the time. But we would be a year post-op at this point. You realize that? That's when they're like, is there a recent x-ray? I'm like, no, what the F? So that was frustrating. Yeah. So that was one I actually had to write a letter. And it was probably one of the angriest letters that I've ever written. Yeah. Delaying this person's surgery is going to you fucked them up. Permanent impairment. Yeah. But yeah, insurance companies are honestly crazy like that. I'm like, dude, just think about it for a second, but they don't. And then you create a bunch of extra work for yourself on the back end. What about do you have certain things that you document in a way that maybe means something different to you than it looks like when you document it. Like you give yourself like little clues.
A nugget, yeah.
Yeah. Little signs, if you will.
Yeah. Mm-hmm.
Hieroglyphics.
Yeah. It's code.
Mm. Yeah. Code.
I'll leave myself some like hidden things, notes to myself, to my future self.
Yes. Mm-hmm. Yeah. I have like little symbols and asterisks and things that I use.
Oh, you literally use
literal symbols. Oh. Yes. And those mean something to me.
Got it. No, I don't have that.
Yeah.
I don't have that.
Yeah. Just for documentation purposes.
Okay.
Yeah.
Okay. Something to think about.
Yeah. It's just a way to inform your future self. But
so, do you think that daily, and you see 30 plus patients when you're in clinic, do you think these battles of like, shouldn't I, am I going to go to bat for this patient because I really want them to get this outcome, and maybe turn my facts a little bit to get the insurance to approve it? Do you how do you feel when you walk out of here at the end of the day?
If I am doing something that is better for the patient, I feel good about that.
So
because
overall,
F the insurance companies, right?
But overall, if you leave here knowing that you have satisfied that patient to get the outcome that you think they need, good to go. Yeah.
Yes. And
I think that trumps it all.
It does. Yeah. It does. And of course, like going back to the other stuff, it depends on like the legitimacy of everything, right? Like I'm going to go to bat for those patients where it is a legitimate thing. Yeah. And I'm not going to approve the 6 months of not working time for something that it's not a legitimate thing, because then I would leave feeling icky. Like I was one of those providers that, worked in Florida in the 90s who was handing out Oxy for contributing to the opioid crisis.
Yeah, no, I think those people still went home and felt okay about themselves.
Yeah. But like in that sense, you are doing it for the reviews and which like, I mean, for me, it's not, I'm not getting extra money by appeasing workers' comp cases and stuff. But
so do you think that you take and there's a certain amount of emotional like energy that goes into this? Again, you get like ridiculously angry at insurance companies. You want your patient to have this outcome, and then you're talking to a case reviewer that like is reading from a stupid chart, and they don't know your patient.
Yeah.
They don't know that they're suffering. They don't know they can't raise their arm up. Do you feel like that overflows into your personal life? Like, do you spend the same amount of emotional energy making decisions in your personal life?
No, I don't spend any.
You don't?
Like making personal decisions? No.
Yeah,
maybe that's why my personal decisions suffer.
Oh, I mean, well, I guess what I'm saying is like you're 100% on at work, and you're advocating for these patients, and you're like, I'm going to do the right thing.
Yeah.
Does that separate when you get in your car?
Yeah. Yeah. I don't know. Wait, I don't know. I think I see where you're going with this on the outline though. Like, yes. Do you then feel like blurred boundaries in other areas?
Yeah. Or do you feel like you've wasted so much emotional energy that outside of work, you have the exact opposite, like, so
kind of, yeah.
Yeah.
Like,
well, that's what I'm asking. Like if your scale needs to be even and it's tipped like this, then you've got nothing left when, outside.
Yeah.
So that's what I'm asking.
Yeah. Like go sit out on my patio, take a shot of tequila and smoke a cigarette and be like, fuck it all.
Yeah. Like you did your best here, and then you're just going to throw caution to the wind. And you're actually going to sit on your railing on the third story with a shot of tequila and your cigarette. And you're like, now I feel good.
No, that's how I feel the best. Yeah.
I think, what I'm saying is I think I
don't smoke, but
tequila's okay.
Just like tequila.
But I think the emotional fatigue of something like that can boil over. I think, and then it's hard to keep that all the time, because you're your patient's advocate. You're trying to do what's right, and you want your name attached to right decisions, right?
Yeah.
And then outside, like for example, yesterday my 16-year-old was, I don't know, I came home and she wasn't home, and I didn't realize she was going out. So I called her. I'm like, where are you? She's like, I just went for a drive. And I was like, okay. And my husband was like, there are 0 follow-up questions to that. And I was like, yeah. It's like, who's she with? Where's she going? Yeah. Are you coming back? Are you going to stop anywhere? And he's like, why would you just okay that? And I was like, I don't know. Maybe it
seemed like
it was because that workers' comp patient took it out of me. I don't know.
Yeah, like it was the easier option.
It was the easier option, but I don't do that at work.
Yeah.
You know what I mean?
Yeah, so because again,
my scale is tipped.
You're expanding all of you hit your 40 for the
I hit my 40.
So you're done. Nothing else. But yeah, I mean, I think that is tough, like separating that.
Yeah.
emotionally. And so people find their own coping mechanisms to deal with that.
Do you think,
bad,
do you think if you knew that patient interactions and stuff like this, if you knew that in school, that you would want to still get into the PA profession?
Yeah.
I do too.
Yeah.
I do too.
Yeah. No,
Did you have anything at school that like prepared you for that?
No.
I
mean, we had an ethical class. I'm pretty sure we had an ethics class. So let me like not go out here and say that Elon did not provide me with ethical, stuff
but not
preparation.
I guess
it's different in real life.
In ethics class, like in PA ethics class, it was more like this patient's on like, life support.
Yes.
And then the daughter says yes, and the son says no.
They're Jehovah's Witness and blood product.
Yeah. So the heavy stuff, I feel like that's like, but it's the other stuff. It's like the everyday stuff that these minuscule
the gray area,
things.
Right?
The gray area.
It is a gray area because like what do you do in that instance where somebody is telling you, they're looking you in the face and they're like, I can't go to work right now because my finger hurts and it only bends this much.
God, yes.
And like, how am I?
I saw there's an Asian lady who couldn't stock soda because her one finger couldn't bend. I'm like, girl, I literally could stock soda like
with two fingers.
Yes. I'll do it with my feet if you want me to. Yeah, I remember that. Oh my God. She's like, but I can't.
Yeah. So like, what do you do in those instances? Like, because school teaches you to be empathetic, you want to be empathetic to your patients and you want to believe them and all of that stuff or whatever. But like, how do you move forward from that? Do you say, oh yes, like,
you're right,
you are definitely going to need to be on disability for this. Yeah. Or do you look them in the eye and be like, no, sorry, like PT.
Honestly, it depends. It depends.
Bye.
And I do a lot of like, if it were me, do I really think that this is something like, you also have a left hand.
Yeah. And I like, sure, I feel for people with that, but like, again, what would you do in that situation? Beth, if you couldn't bend your finger a little bit, are you going to like not show up to work?
No.
I mean, like, what's the option here?
Yeah, no. I mean, but again, I think it's different per person, but it's not your job to tell people what their capabilities are because everyone's capabilities are different, but also it is your job to tell them that.
Yeah.
Because worker comp makes you do that.
Yeah. Yes.
So I don't know. I mean, I will try to do the best possible thing for the outcome of the patient. Do I think sending them to work, even though they look at me and they told me, I'm not going to work? I had a lady the other day that was like, I am not ready to go back to work. Oh my God. I can't believe I didn't bring this up. I'm not ready to go back to work. I'm like, well, you're 2 months after rotator cuff, so you can do this at work.
Mm-hmm. Yeah, like the
sit
typing,
at a desk and you type. And she was like, if you provide me with that note, I'm also going to need a mental health referral. And I was like, for what? She goes, because of the emotional impact of going back to work.
Situation.
I was like, but no, she didn't say that. It wasn't unsafe. She just wasn't mentally ready to hear that. Mm-hmm. So 8 weeks ago, when we talked about timeline for return to work, this 100% was covered. So she said, I need you to put me out of work. And I was like, well, it's my obligation professionally to say what you can do.
Yes.
Your work may say, you can't, nothing to offer you in your home. She's like, but the indecision also now is making me stressed out. So I need a mental health referral. And I wrote in her note, okay, we discussed going back to work. Patient can very easily work at a desk and type. Upon further discussion, the patient conveyed that she was very, very upset about this and she would like a mental health referral. We also discussed keeping her out of work just for the whole mental, health. Mm-hmm. And I didn't think it was very strenuous for her to do that. So she called me and she was like, take it all out of my note. And I was like, I'm not going to do that. Yeah, I'm not going to do that. Yeah. That was this week. And I was and she was very reasonable in the room, but as soon as it was returned to work, and my brain is like, did you have a vacation plan?
Yeah, like what's making you react in this way?
Yeah, is there a show that's coming out that you need to binge? Like, I mean, I don't know. But I'm not going to say that she can't physically type at 8 weeks after rotator cuff repair because she's not ready to hear that.
Right. No, I go through that all the time. Like, I can't physically take you out of all things. I'm just going to say what you can and can't do. So if this finger doesn't bend down all the way, I'll say like, that finger doesn't bend down all the way. Like,
type J, U, or N on the keyboard
quickly at least.
The finger can't get there.
But they can make the reasonable accommodations based on that.
Yeah.
But yeah, we had a patient. I think somebody that you guys had as a shared patient as well. Same kind of thing, but this was like 10 or 12 weeks after their surgery, and I sent them back to work, which was a very reasonable time frame for what they had done.
Yeah.
Just back to like typing and driving.
Yeah.
Was mostly all they did. And yeah, they basically continuously messaged my staff back saying that it was unsafe for me to have done that. I was messing things up for them, and
why would you do this?
Ruin their life, made them worse, all of the things.
So what can we learn from this conversation?
So I think continue to advocate for the patient. Like, again, that's what it's all about. Like, we're going through these motions, documenting things the way that we're documenting them, you know, having these conversations with insurance companies, having these difficult conversations that are maybe a little bit uncomfortable with them, all for the betterment of them and the outcome, and just so that everybody's on the same page. So even when those things are uncomfortable, doing it, because part of the job. And then also just, you know, we're all in this together, having the same experiences of the workers' comp calls and the unreasonable expectations. So I don't think that part is going to go away. And I don't know that there is a great answer for that on how to deal with it. It's just something that, you know, is going to happen, and try to not take it personally, I guess.
Again, I know
you can't take it personally.
Back to that.
Yeah.
I think ethical struggles are there every day. And again, I say struggle, it's not like it's a battle, but like you got to check yourself every single day and not do what's the fastest, easiest, do the right thing.
Yeah.
Right.
Yeah. And you will find yourself some days you do get a little bit burnt out, and you're like, hey, I'm going to just order this MRI because like, God, I can't.
I can't tell you again why I'm not going to.
Yeah. So we're just going to do it. Now, are those like huge ethical and moral slip ups? No, like it's fine. It's appropriate in a sense. Still, it's just, you know.
Yeah. So
the burnout showing through.
But we are humans, right? So we're not going to be perfect. We're just doing what's best. But I think if you have that ethical compass that's in check and you continue to reference that, that's the key. And also, are you ready for this?
I don't know.
Ethical courage is a muscle.
Ethical courage is a muscle.
You build it over time, just like your glutes. Yeah. So, well,
I think my distance running wearing?
I don't know. I'll ask ChatGPT. I'm not really sure
about that.
But I think you're human. You're going to get it wrong. But having the courage to have those discussions, uncomfortable or otherwise, I think is huge. So we're not here to try to be perfect. We're just doing our best every day and trying to grow those glutes.
Grow those ethical muscles.
That's right.
All right, guys. Thanks for joining us. We will see you next time.
Bye.
Bye.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.